Okay. Okay, so I hope you've received the. I've sent it to you. So what we normally do is that unfortunately I don't have a projector, and the projector with the school is really on demand. It's a problem to book it. So how we normally do the class is that since we're meeting for the first time, so normally I send the PowerPoint to you, and then you can follow on your phones. All right. And like always, the lecture will be recorded. You can make reference to it later, and also for the benefit of our colleagues that are not here. That's why you see me with a little mic and all that. Okay. So obviously, I'm Kauma Chimbarantu. I'm a nuclear medicine physician. You probably may wonder why a nuclear medicine physician should be talking physiology. You see, my specialty is all about function. So physiology is an important component of nuclear medicine. And I thought, why not make some fuel money, with Crystal University. Anyway, so we're talking blood today, slide one. If you remember from our discussion on the second part of the membranes and the tissues, one of the examples of connective tissue was actually blood. I'm sure you may know already that blood is composed of a liquid part and of cells. Obviously, the liquid part of blood is called plasma. There are a number of types of cells that you're going to find in the blood. And for your information, you may know that this liquid part of the blood, which is called plasma, makes up 55% of blood volume, whilst the cellular part makes up 45% of blood volume. I'm sure you also know that this blood is very important for the body in that it helps to keep a constant environment, the homeostasis that we always talked about. How does it do that? By making sure that the various type of cells in the body are supplied with the nutrients they need to continue generating, shall we just say, to continue performing their normal functions. But at the same time, the blood also makes sure that it takes away the waste products of metabolism of the various parts of the body so that they can be excreted either through the lungs, the kidneys, or the skin, as we have learned already. Slide 3. So we can briefly discuss about, talk about some of the functions of blood. We already know that one important function of blood is that it carries oxygen from the lungs to the various cells of the body. It obviously carries nutrients from the GI to places where they are required. Blood is also important in the fact that it also carries, you could say it's a vehicle and will carry hormones from the site of production to target organs. Blood is also important in the fact that it is able to distribute heat in the body. How does it do that? It's able to carry the heat from the site of active tissues to sites of less active tissues. It is also important in protecting the body in that it is able to basically transport antibodies, which are basically agents that protect us, from, pathogens. So it is able to carry these antibodies from a site of production to a site where it may be needed. Blood also contains what are known as clotting factors. The clotting factors are very important in that they help us basically maintain the integrity of the cardiovascular system. What do I mean by that? In an event that there is damage to a blood vessel, the clotting system does come into play and will arrest, the site where there's been damage in the blood vessel. So like we've already said, just to try and expand on it, blood is composed of a liquid part and a cellular part. We did say that the liquid part is called plasma, while the cellular part is made up of several types of cells, including the red blood cells, the white blood cells, and the platelets. Interestingly, the white blood cells have two categories. So you've got what are known as polymorphonuclear leukocytes. The polymorphonuclear leukocytes shouldn't sound complicated. It's basically granulocytes. And you also have mononuclear leukocytes, which are basically granulocytes. So what does this all mean? Granulocytes are basically a group of white blood cells that contains granules. Once you see this thing that we do when you're taking a blood film, the malaria. Okay, yeah, well, yeah. You take a slide, you put a little stain on it. Most of the stains are going to accumulate in this type, the granulocytes. So the appearance of the cells will be that there will be a nucleus, but in the cytoplasm, at the center, but in the cytoplasm of these granulocytes will be little granules like that will take up the stain. Hence the name granulocytes, from the granules. Okay? The agranulocytes are the type of blood cells that does not have granules on the stain. Instead, what do they have? They've got a very large nucleus in the center. And examples of these the lymphocytes and the monocytes. And examples of the granulocytes are the eosinophils, neutrophils, and the basophils, as you're going to see a little later. Right, so a little bit more detail on the plasma. We've already said that the plasma is the liquid part of the blood. This liquid part of the blood is made up of 90% water. It has a number of dissolved constituents. Some of these dissolved constituents are plasma proteins. And an example, do you know that? Do you know an example of a plasma protein very common in the blood? Would you like to give us an example? Albumin, yes. Fibrinogen, yes. Globulins, yes. Albumin, let's start with albumin. Albumin is a very important protein. How important is it? Absolutely. What is oncotic pressure? Do you know what oncotic pressure is? Absolutely. What is it?
So, oncotic pressure is the pressure that maintains the balance in terms of movement of fluids from intracellular to extracellular.
Okay, to put it very loose, so oncotic pressure is sort of the pressure that pulls water within the vascular compartment. I'll give you an example. If somebody has got nephrotic syndrome, you know what nephrotic syndrome is? What is it? A common test that we do in the clinic is a urinalysis test. Most of the time, we should not find protein in the urine. And we are going to discuss this next semester because the kidney is made in such a way that it's like a sieve. But the sieve are designed in such a way that the cells and the proteins should not come out. Only water should come out at the level of the kidney. But when the protein starts to come out, meaning that there may be kidney damage at the basement membrane. So when you start to see the protein in the urine and a lot of it, you've got most likely a kidney problem. And in many times a case, it could be, you may be dealing with nephrotic syndrome, and it will eventually lead to a reduction in the amount of albumin in your vascular compartment. What will happen is that because there's reduced albumin, there will be reduced oncotic pressure, meaning your ability to keep the water in the vascular compartment is now less. Where is that water going to go? In the interstitial spaces. That is why people with nephrotic syndrome will have swollen feet. It's the same explanation why people with kwashiorkor, children with kwashiorkor malnutrition, will have swollen feet. Or extremities. It is because the fluid is in the interstitium. It's the same explanation for people that may have chronic liver disease, because we know that the albumin is produced in the liver. So if the site of production is disturbed, then you have reduced amount of albumin, then reduced oncotic pressure. Yeah, absolutely. You don't only find albumin as the only protein in the blood. You also have other proteins such as the globulin. Oh, by the way, what are some of the functions of albumin? I've told you about oncotic pressure, but albumin also functions as a transport molecule. So there are some molecules that bind to albumin for transport. So another type of protein you'll find is globulin. In fact, this should be an exciting exam question. I think we should propose that it is changed. Yes, should be nice. Short notes. Yes. The question would read, what briefly describe the proteins or list the proteins that are found in the vascular compartment and their functions. So it will be albumin, globulin, fibrinogen. There are others obviously, but these are the ones we're discussing today. The globulins also function as transport, very similar to albumin, also function as transport molecules, but they also serve as mere, antibodies themselves. Should be exciting. Fibrinogen is an important component in that it's an inactive form of fibrin. And what does fibrin do? Fibrin is what forms, a platelet plug. Sorry? Absolutely. So it sort of goes on the platelet plug and makes it strong. Right. Moving on. I still hope I have my mic. Okay. Okay, so apart from so we're talking about dissolved components of the blood. So we've spoken about proteins. I would like now to tell you about, so you also have inorganic mineral salts. So what are some of these inorganic mineral salts? We're talking about everything: sodium, potassium, calcium, and bicarbonates, those kind of things. What are the functions of these inorganic salts? Okay, so we know, for instance, remember when we spoke about all that nice sarcomere, tropomyosin, and actin? You need calcium for the whole process to start. So it's very important in helping us to contract our muscles. We also know that calcium plays an important role, especially if you talk about cardiac muscle. For cardiac muscle to generate an action potential, you need calcium. Sodium and potassium, very important for you to generate an action potential, as we are going to learn next semester. We also know that blood is going to have, especially if you look at the portal vein. So portal vein is basically the vein that's coming from, have you listened to the GI? It's coming from the liver. It's okay. It's coming from to the okay, hepatic portal vein. Uh-huh.
So there are types of hepatic
Uh-huh. Uh-huh.
transformation
Uh-huh.
supplying to,
Uh-huh.
but it comes from when it comes from the liver, it's called hepatic.
And if it comes from, madam, you're not learning anatomy. Okay. So what is the vein we are looking for? Okay, so we are talking about the vein that's coming from the GI going to the liver. What is the name of that vein? Yes.
Is it the hepatic
Portal what?
hepatic portal?
It's the hepatic portal vein. So what is going to be found in the hepatic portal vein? Plenty of nutrients. amino acids, monosaccharides, because they've just been absorbed from the GI. So, by saying that, I am trying to say blood is also going to carry some of these nutrients. Yeah, we're talking about dissolved components of blood. And I'm saying that blood will have some of these constituents because they'll be absorbed from the GI and they'll be delivered to where they're needed. Okay, apart from delivering these nutrients, blood is also going to have products of metabolism, including uric acid, urea, creatinine, which will be delivered to points of excretion, in particular the kidneys. Also, it's no brainer that we've already mentioned it. So I'm on slide 8 now. That blood will also have hormones, so they'll be produced by a gland, and then the blood will transport these hormones to a target organ. We also know that the blood is going to have gases. We spoke about the oxygen and the carbon dioxide. We know that the oxygen will be transported mainly by the hemoglobin, and the carbon dioxide will be transported in a dissolved form as bicarbonate, but also a little bit of carbon dioxide may be transported in the red blood cells as well. I'm on slide 9. I'd like to give you a bit more detail on the different types of cells that are found in blood. We've already said that there are red blood cells, which are also known as erythrocytes. There are white blood cells, which are known as leukocytes, and they are platelets, which are circular kind of cells, but that do not have a nucleus. So all these three cell lines come from a common cell, which is known as what is this thing now? Pluripotent, pluripotent stem cell. And it will so happen that each of these three cell lines will then pursue their respective cell lines. The process of producing blood is referred to as hematopoiesis, and blood production takes place in the red bone marrow. In addition to lymphoid tissue, which is basically responsible for producing lymphocytes. Do you know where this red bone marrow is found? Oh, by the way, the lecture is on the phone. So you came late, so you missed the announcement. So you just go to the group, you will find it. Do you know, guys, the site of blood production? Do you know? Do you know where blood is produced? Okay. Only? In what circumstances? Yes, sir. Yeah.
We have mentioned the red blood cells.
Yeah. Yeah.
Then also on the skin,
Yeah.
which also helps information. So usually in the skin, that's where maturation takes place. So they'll be produced in the
Yeah.
bone marrow.
You are correct. What if I told you that the site of production, or rather the hematopoiesis or hemopoiesis, um, differs depending on the age group. So in children, the production of red blood cells will take place both in the red marrow, but also in the liver and the spleen. But as you grow older, the production of, or the process of hemopoiesis or hematopoiesis, will only be reserved for the red bone marrow and no longer the spleen and the liver. I think there are cases when the liver can be and spleen can be reactivated. I think I've heard of things like post-chemotherapy, those kind of things, under stressful conditions. It is possible that the liver can produce the red blood cells again. So the question is, where is your red marrow? Where do you find the red marrow? You're not confident enough. Madam, the lecture is on the phone. Check the group. You wanted to say, sir?
I think the red bone marrow is found at the, let's say, proximal end of the
Okay, I like it. I like it. Proximal.
end of the bone. So you have the
Sounds good.
you have near the joint, because we find some.
So let's just say, so proximal femur.
Yes.
So red marrow is found in the axioskeleton and the proximal appendicular skeleton. So what is the appendicular skeleton? Appendage. You see, this is appendicular, so proximal part of it. Proximal part of it. And the axioskeleton. So this is the axio appendicular. You understand? All the axio and proximal appendicular. That's where your red marrow is. Okay.
So, you say in adults usually see the bone marrow.
Yes.
And what happens perhaps maybe or maybe someone has undergone this period of, can they still survive knowing that the bone marrow is still producing?
Yes. It's an interesting question that you've put. Look, when you're an adult, the spleen no longer performs hematopoiesis. So even when you remove it, there's no problem. You know what I mean? However, there are certain circumstances when you have, for some reason, well, you get a spleen, and the spleen is hyperactive. When the spleen is hyperactive in adulthood, what it actually does is just finish your platelets. You've heard of that, huh? So there's a condition like that where I think it's thrombocytopenia purpura something something. I can't remember the exact name. So you patient presenting with very low platelets. You know what I mean? Solution: remove the spleen. You know?
Also stores as a reservoir of blood.
Agreed. It will store, may act as a reservoir of blood, but not much. And in terms of shock, it may push some of that blood back into circulation. But really, you can live without it. So it can act as a reservoir of blood. It's a lymphoid tissue, so there is lymphatics there. But even without it, really, your immune system is not compromised. I mean, splenectomies are done on a number of patients. It's not really, you know, life-threatening. So in short, to answer your question, you can have your spleen removed with no problem. Just like you can have part of your liver removed with no problem. At any particular time, I think you're utilizing only 1/3 of your liver. If everything is normal, only 1/3 is being used, sir. Yeah. But unfortunately, when cirrhosis starts, you won't even know that it has started. So we should drink good things. Proceeding. So we already talked about, so now we want to speak about in detail, basically on the cells. We want to talk about, I think, maybe we should just go into and talk about the erythrocytes. But in slide 11, basically what you're looking at is the diagram that shows you the pluripotent cell, which is like the ancestor, the origin of all these cells. And you can see that from the pluripotent stem cell, you have the proerythroblast. It is from the proerythroblast where you have production of the erythrocytes, which are the red blood cells. And you can also see that from the pluripotent stem cell, you have production of the megakaryoblast. which is sort of the cell line that then gives us the thrombocyte, which is the platelets. You also have the myeloblast, which is the common ancestor for all the granulocytes. What are the granulocytes? The basophil, neutrophils, and the eosinophils. The granulocytes have don't they all come from the pluripotent stem cell, but they don't have the same ancestor. You can see this. So you can see that the monoblast gives us the mono the which one is this? The monocyte. While the lymphoblast gives us the lymphocytes, which are of two types, the T and the B. All right, so it's quite easy there. I'd like us to talk about slide 12, which is the erythrocytes. And by the way, in the last exam, there was a short notes question, and it was general. Write short notes on the erythrocytes. So should this question be repeated, here is your answer. So erythrocytes, also known as the red blood cells, are basically biconcave discs which do not have a nucleus. They have a diameter of about 7 micrometers. The main function is obviously to transport gas, mainly oxygen. So instead of having a nucleus, their center has got a very well adapted protein, which is called hemoglobin, and it's a combination of heme, made of iron, and protein, which is the globin. There are 4 molecules of this hemoglobin in each cell of the red blood cell, and this hemoglobin is responsible for temporarily binding to oxygen in the lungs and delivering this oxygen to the site where it is needed at tissue level. When this hemoglobin reaches tissue level, or what I didn't tell you, is that this RBCs produced in the red bone marrow by a process called erythropoiesis, which takes about 7 days. After 7 days, you will have immature red blood cells that will be released in circulation. These immature red blood cells are referred to as reticulocytes. It takes about 2 days for these immature red blood cells to mature to full-size red blood cells. Madam, do you want to stretch? Let's stretch whenever you are free. The lifespan of a red blood cell is 120 days. I'm sure that you know already. So if, let's say, you're asked to write those short notes on the red blood cells, you've got all these points, there are plenty. They say that the red blood cell is very well adapted for its function. Number one, this thing is biconcave, so it's like this. You know, it's like a donut. You know, a donut. You're adult, so you don't eat donuts. But me and my brother, whenever we meet, it's family tradition. We do a lot of donuts. I'm not talking about the donut, the long ones, but you know, the American donuts, you know, at least. You understand? So the red blood cell is like that. So at the center is a bit narrow, but on the edges it's sort of like that. You understand? So basically your red blood cell is like that. So that's what we say. By being biconcave, it sort of increases surface area, you know, for the gaseous diffusion to take place. It also, they say, because the central part is thin, and that's why you have your hemoglobin, it also makes it easy, you know, for the gas to, you know, basically diffuse in between the cell. Another important ability of the red blood cell is it's flexible, you know, it doesn't play games. It can, you know, a cat. So have you ever kept guinea fowls before? Not guinea fowls, guinea pigs. Where did you grow up? I'm so sorry, guys. This could be the boss. Excuse me. Yes, Madam Delia. Yes, morning. Yes, yes. He doesn't know. Yeah. No. Ye- Yeah. No, it's okay. I'll be coming. We'll sort it out. We'll sort it out. Okay. Thank you. Okay. So, guys, it's quite a long discussion, but it shouldn't be so long. Apologies. So, anyways, I was saying, so I was trying to tell brother about my experience with the guinea pigs, if you know the guinea pigs. So as a child, I used to keep guinea pigs. And unfortunately for me, the cats would always come and eat them. Even when you have a very small opening, because the cat has this ability to squeeze through very small openings. Apparently, the red blood cells are like that too. So at tissue level, very small, tiny capillaries, these red blood cells can squeeze through, so to make sure that they can deliver the oxygen to the various cells of the body. But sometimes things go wrong. Like in what condition? Sickle cell disease. In sickle cell disease, the red blood cells do not have this flexibility because they can't squeeze through easily in these small capillaries. They're too large, they clog the flow. And when they clog the flow, distal to the blockage, there will be no perfusion. The ischemia will cause the pain. Hence the pain in vaso-occlusive crisis, basically. You are experts. Why am I wasting time? So apparently, in addition also, apart from not having the nucleus, the red blood cell also lacks some of the organelles that we learned about in a basic cell. This also enables it to have that large heme, so that it can then effectively transport your oxygen and carbon dioxide. So you may know that in the production of the red blood cells, some of the important raw materials that you need are folic acid, vitamin B12, and iron. This is the reason why when somebody has anemia, you encourage them to take a lot of, iron and folic acid supplements. You may wish to know that all these are absorbed in the GI, in particular, vitamin B12 absorbed in the GI. However, to absorb B12, you need intrinsic factor, which I think is produced in the, in the stomach. I should give you the GI lecture because there are MCQs and short notes on GI. So please go through it. Okay, so I'm on slide 15. So we already know about hemoglobin and how it transports this oxygen. We already said that it is made up of 4 molecules. And if these 4 molecules are bound to oxygen, this hemoglobin molecule is referred to as saturated. If maybe it is partially bound, that is, maybe you still have 2 molecules and 2 molecules are bound, then it is unsaturated. So how does the oxygen then at capillary level, at tissue level, leave the vascular compartment into the tissues? It is because at tissue level the pH is higher. You know what I mean? As a result of the metabolism going on at tissue level, the environment is slightly, the pH is lower. You understand? And the oxygen levels at the tissue compared to the vascular compartment at the tissue is lower, and there's more oxygen here. So the oxygen simply diffuses. You understand? And the fact that, so an increase in temperature, so you can assume for a highly active muscle, let us say I'm an athlete, if I'm using my muscles, the temperature at muscle level is going to be higher. This will also encourage oxygen to leave the hemoglobin into the tissues. Obviously, from a clinical standpoint, on slide 16, hemoglobin, for us knowing the level of hemoglobin in a patient is something very important, and it's something that we will see on full blood count. If you look at this picture, I'm basically trying to show you some of the parameters that we look at, that, and that gives us a picture of how much somebody, if they have adequate hemoglobin or not. And you can forget about all these other parameters, packed cell volume and all these things. Most of the time, what we look at is the hemoglobin itself, either per mil, per liter. And this is really not in our population, because in our population, we accept much lower values, because, this has to go with diet, and, also goes with socioeconomic status and all those kind of things. But basically, it is acceptable that for a man should have a range of about 13 to 18 grams per 100 milliliters, and a woman should have between 11.5 to 16.5 grams per 100 milliliter. This also varies depending on the laboratory. So it's always essential to look at the reference values for that particular laboratory. I'd like to quickly jump to slide 18. So the production of these red blood cells, or by the process of erythropoiesis, is controlled, or the stimulus that makes the body to produce more and more of the red blood cells, is because of a response to hypoxia. Hypoxia, which is basically deficiency of supply of oxygen to the cells of the body. What are the circumstances that may lead to this hypoxia? So it could be that your red blood cell, for whatever reason, your blood has reduced oxygen carrying capability. And this may happen, let us say, if you lose large amounts of blood for some reason or the other. Or it could be that maybe you've gotten sick, you've got sepsis, and you've got massive hemolysis of your red blood cells. And if you lose the red blood cell mass, obviously you are going to lose your ability to deliver the oxygen to the parts of the body. Or it could be that all of a sudden, Madam Tukwiza is the name, yes? Uh, is that you, man? Oh, how could I miss you? It is understood. You know that most of our nurses are on high demand, Finland, UK, Canada, and all those kind of things. You know what I mean? So supposing that you migrate, madam, let's say you go to Kenya, and it is very high altitude. And you know that as you move from sea level to a higher ground, the air thins out. So meaning the amount of oxygen at a higher altitude is less. So what your body is going to do is going to initiate more and more production of red blood cells. It is no wonder the Kenyans are very good athletes. You know why? Because they naturally live on higher altitude. It means that if we were to take an HB of a Kenyan and your HB, you are likely to have less than them. And if they have a higher hemoglobin mass, meaning that they can deliver more oxygen to their muscles than you, it means that then they can perform a task much more efficiently than you, meaning that they have that unnatural advantage. You understand? So endurance races, they do very well. You can't easily beat them. Absolutely, guys. I'm talking too much. Yes? You want to stretch? Absolutely. So, guys, the process of erythropoiesis, which we say the stimulus is hypoxia, what will happen? So, Madame who has moved to Finland, which is a mountainous land and hopefully earning lots of dollars, And hopefully you're sending some of that forex back home so that our dollar can get better. As you can see, we're in free fall right now, and it's very sad. If you've got your savings in kwacha, yeah. But if you've got dollars, you'll be excited, yes? Anyway, so when you go to that high mountainous place, and all of a sudden your body is telling you, oh, we are not receiving enough, oxygen, what will happen is that the kidney will be called upon to produce a hormone called erythropoietin. The hormone erythropoietin is going to encourage increased production of your red blood cells from your red marrow. Okay? Absolutely. Ladies and gentlemen, and I'm on slide 20. I'd like to quickly tell you about the blood groups. You know already. So the red blood cells may have certain antigens on their surface. You do know that the cells of our bodies have got antigens, molecules. Remember when we looked at the plasma membrane? We talked about glycoproteins. And the combination of these glycoproteins signals where this cell belongs to. For instance, my cell, the configuration of my glycoprotein and the configuration of glycoprotein on your cell are very different. It's very easy for your immune system, to depict that it's not me. You know what I mean? Let's say if we introduce your cell in my body, my immune system will pick it immediately that we've got a foreigner, we've got an invader in the land. Let us mount some resistance. You understand it? So, the red blood cells are like any other cell. They also have these special configuration on their surfaces that are called antigens. There are many types of antigens, but the most common that is known is the A-B system and also the rhesus. So in most individuals, you are either going to have the A antigen, or you are going to have the B antigen, or you are going to have a combination of A and B, or you are not going to have any antigen at all. You understand? Right. When you have the A antigen, the body is going to have antibodies to B, but not A. You understand that? When you have the A antigen, your body is going to have antibodies to B, but not to A. You can't attack self. You understand that? Otherwise, you wouldn't be alive. All right? When you have the B antigen, you're going to have antibodies to A, but not to B. When you have a combination of A and B, you're not going to have antibodies at all. You understand it? When you have no antibodies, none of the A and B, what am I saying? When you have no antigens, none of the A and B, you are going to have antibodies to both. And when you don't have the A and B antigen, that blood group is called O. You do understand it? To make it easier for you, in fact, in the last exam, we had a long essay on this question. Please check slide 23. In slide 23, you see this table. You've got blood group A. In blood group A, this bean-like looking thing is the red blood cell, and you can see that on its surface it's got antigen B. And you can see that in the plasma, the antibodies are not A, but are antibodies against B. And you can see that a person that has got blood group A can, as a donor, can donate to somebody that has A and that has AB. You know why? Because when you take this red cell mass and give it to somebody that has A, there are no antibodies to A. So there is no problem. So somebody that has blood group A can donate to another person that has blood group A. No problem. But they can also donate to somebody that has blood group AB. Because in somebody that has blood group AB, this person has no antibodies to either A or B. So it's okay. You understand? You can also see that as a recipient, a person that has blood group A can receive blood group A, it's no brainer, but can also receive blood group O. Because blood group O, it will not come with antibodies. It will just come with a red cell mass. And blood group O does not have any antigen. So even though somebody that has blood group A has antibodies to B, they can receive O because O has no antigen. So it's okay. You understand it? That's fine. You can also see that somebody that has blood, this is quite clear. I don't have to take you through. You can read on your own. So before you sleep, let me tell you something else. Right, are you clear? This was actually a long 20 marks in the last exam. So just in case they get careless and they repeat it, don't ignore. All right, absolutely. Moving on. Apart from the ABO system, there's also the rhesus system. The rhesus system, some people refer to the rhesus as antigen D, if I remember correctly. It's more than 10 years ago I did this basic physiology. But I think they refer to it as antigen D. So it may so happen that this is actually very important, let's say, in the settings of pregnancy. You may know already. So what sometimes may happen is that a woman, may not have this antigen D on the surface of their red blood cell, in which case they will be called rhesus negative. And the husband, and by the way, the majority of people are rhesus positive. So the majority of people will have this antigen D on their surface. So the likelihood that a woman who is in the minority, who has rhesus negative, will marry somebody that is rhesus positive is very high because the majority are rhesus positive. You understand? When these two people marry, what may happen is that the baby may be rhesus, well, the baby may be rhesus positive. You do understand? Because the baby can get the gene of the father. You understand? Unfortunately, as part of the blood, usually the first pregnancy, there are no issues. Usually no issues. But as the mother is being exposed to, for subsequent pregnancies, the mother is being exposed to this D antigen. Remember, she doesn't have the antigen. She will form antibodies. You do understand? Such that the subsequent pregnancies she may have of babies that will be rhesus positive, the antibodies may attack the fetus. You do understand it? And you may have a poor outcome for the lady. Right. So that's some knowledge to know when you're counseling couples before they get married. Oh, there's this thing. You don't know. So you just know the HIV, but you may also want to check on the blood grouping system. In my slide in 24, am I that boring, madam? And I'm not even halfway. Okay, let's speed up. You can also see that in slide 24, I am saying that somebody who's rhesus negative can comfortably donate blood to somebody that's rhesus positive. Because somebody that is rhesus positive, These people that do not have the antigen, there's no issue. The blood can come. They can also donate blood to those that are rhesus negative as well. However, somebody that is rhesus positive cannot donate blood to somebody that is rhesus negative, because the person that is rhesus negative is going to form antibodies against the exposure, and there may be a bad outcome. Very quickly, guys, I would like to just give you a little bit of detail on the white blood cells. So we have the granulocytes and the agranulocytes. We've already talked about it. So the granulocytes, we did say, come from a common origin, which is after the pluripotent cell. They're going to come from the myeloblast before differentiating into the cells that eventually give us the basophils, eosinophils, and the neutrophils. So the interesting thing about the granulocytes, apart from having these granules in the cytoplasm, is that the nucleus is bilobed. All right, that's one interesting thing about them. We can skip slide 27 and go to slide 28. You can see on the right side, I do have a sample of how these granulocytes are going to look, and you can see that the nucleus, is bilobed. This gives them the ability, to basically engulf, let's say, invading bacteria, fungus, virus, those kind of things. So there are three types of these granulocytes. We've already mentioned the neutrophils, eosinophils, and basophils. So let us look in detail about the neutrophils. So the neutrophils basically useful in the defense against foreign material that are entering the body, and they are also useful in removing waste material. An example would be dead cell debris. So these white blood cells move by chemotaxins. So what would happen is that sometimes when there's a site of infection, the site of infection is going to produce certain chemicals. These certain chemicals are going to cause the movement of these neutrophils to the site of infection, basically. In addition, these neutrophils are able to come out of the vascular compartment into the interstitial spaces, and when by a process called diapedesis. Okay? In addition to having a bilobed nucleus, the cytoplasm, the granules that we spoke about, are basically lysosomes. And when we spoke about the cell, we said lysosomes are basically organelles that are going to contain enzymes. So you can imagine that when this neutrophil engulfs bacteria, it's then going to release the its enzymes on the bacteria, and these enzymes are going to digest and neutralize the bacteria like that. So without wasting much of your time, we can quickly talk about the eosinophils. The eosinophils, also part of the granulocytes, similar in shape, but not as active as the neutrophils, and these are basically responsible for eliminating parasitic organisms. Okay? Examples like worms that cannot be basically phagocytosed. They're also responsible for regulating inflammation, so either to promote or to dampen inflammation. You also have basophils. Basophils associated with allergic reactions. So, they contain a lot of these histamines, very similar to mast cells and things like that. Yes, please.
So the white blood cells, what is the cause of the abnormal cells? Abnormal cells, the multiple cause of the white blood cells. What could be the cause?
Abnormal growth or abnormal number in what? You mean a shape?
Number.
Abnormal number. It could be, maybe there's, because what are you talking about? Okay, so if I understand your question correctly, if We give a practical example. Let us say there's obviously, if let's say we do a full blood count, right? And then somebody says differential count. The differential count then goes into detail and tells us, okay, now goes into how much granulocytes do you have, how much agranulocytes you have. So you'll have, then you're going to list this neutrophils, basophils, and eosinophils, but you're also going to list lymphocytes and monocytes, what they should be. So one of the causes of abnormal number will obviously be an infection. For instance, if you look, I actually skipped this much detail because I wanted to move fast. If you look on slide 28, so we're talking about neutrophilia. So this is the cause of an increase in number of neutrophils. We're just taking an example, all right? So as a general rule, an acute infection is usually associated with neutrophilia. However, a chronic infection will usually be associated with lymphocytosis. You do understand? Okay. So here is the list of an example of things that may cause neutrophilia. So during exercise, they say, late stage of pregnancy, heavy smoking, all right, use of oral contraceptives. It's something that I actually don't like. But it is not well documented. That's my opinion. So don't take my opinion. You can read for yourself. No, I don't. The combined contraceptives. Eish, those things, eh? Leukemia. That's what I wanted to tell you, madam. Leukemia. So, this red marrow can, for some reason, start to produce. So, leukemia is cancer of the blood, you know that. So, you've got an abnormal production of these white blood cells. So, you have an increase in number of neutrophils, and it may be as a result of leukemia. It could be because you've got a metabolic disorder. What metabolic disorder? Example, DKA. You know what DKA is? Diabetic ketoacidosis. Right. Or acute gout. You understand? Another, if we're to talk about lymphocyte in our environment, you know, a chronic infection like tuberculosis. So you're generally going to see somebody with very high counts of lymphocytes, basically. Are you satisfied? We can quickly talk about the lymphocytes. So the lymphocytes basically smaller than the monocytes because the monocytes are basically larger, has a larger nucleus. So these ones circulate in blood and they're greater in number in the lymphatic tissue, like the lymph nodes and the spleen. They are produced in the bone marrow and are activated in the spleen. There are two types of lymphocytes. You've got the B and you've got the T. What is the difference between them? Yes, sir.
The T lymphocytes for the production of lymphocytes and the lymphocytes.
In terms of production, the T lymphocytes will spend some time in the thymus,
Yes.
whilst the B will not. Okay, so the T lymphocytes are processed in the thymus and are responsible for cell-mediated immunity. The B lymphocytes are processed in the bone marrow and will basically be responsible for antibody-mediated immunity. Slide 31, we can quickly look at the monocytes. These also originate from the bone marrow. These circulate in blood and they're actively motile and they are phagocytic, just like the neutrophils. An important ability of the monocyte is that they are able to come out of the vascular compartment and they go into the interstitium and become macrophages. You know what I mean? And an example of the macrophages, for instance, if you go to the central nervous system, which hopefully, if I'll still be around, we will learn together. So macrophages that you find in the central nervous system will be referred to as part of the microglia. In the liver, you will have the Kupffer cells. In the lungs, you have the pneumocyte type 2. In the kidneys, they are referred to as the mesangial cells. In the bone, they are referred to as osteoclasts. All right. You understand it? And this monocyte, the monocyte macrophage system, so that is the monocyte in the vascular compartment and the macrophages outside the vascular compartment are referred to as the reticuloendothelial system. We're almost done. And I'll be gone from your life forever. Only to meet in the exam, eh? So, we can quickly talk about platelets. We've been talking about the cell lines, so we talked about the erythrocytes, we talked about the white blood cell or the leukocytes, and now we want to talk about the platelets. So the platelets are small non-nucleated disc-like cells that are derived from the megakaryocytes in the bone marrow, which also comes from the pluripotent cells. They contain a variety of substances that is useful in clotting, which is an important part of homeostasis, like we've already said. These platelets are stimulated or production of the platelets is stimulated by a chemical known as thromboplastin, which is produced by the kidney. The lifespan of a platelet is between 8 to 12 days. Apart from just storing blood, the spleen is also responsible for storing platelets and only released when called upon. Of course, I mean, things are going to go wrong, but you can live. After splenectomy, talking about the story that me and my brother were speaking about earlier. In fact, well, some people argue that, for people that, these ones, the sicklers, they are also, they have, sometimes you may need to remove a spleen, but when you do that, then they become susceptible to some kind of infections, they like hemophilia, not hemophilia, what is that? I can't remember the organisms, but basically because I think you've taken part of the immunity out, then they become susceptible. But they can live. So you must cover them against some antibiotics and all those kind of things. So anyway, guys, so that's it. I'd like to quickly tell you about, in summary, what some of the hemostatic processes that the platelets are going to take part in when there is damage to the endothelial surface of the blood vessel. So basically, what will happen is that when there is a damage to the endothelial surface of a blood vessel, there will be release of certain compounds. Some of these compounds are called thromboxanes. So these thromboxanes, in part, is going to lead to vasoconstriction of the damaged vessel. And the reason there's vasoconstriction of a damaged vessel is to reduce flow in that damaged vessel. Obviously, if you don't reduce flow, then there will be more loss of blood. All right? But also, these thromboxanes are going to lead to attracting platelets. So these platelets are going to then, once activated, they're going to become sticky and they're going to bind to the surface of your damaged blood vessel. Once they bind to the site of damaged blood vessel, they're going to release serotonin. Serotonin will also help to cause vasoconstriction in addition to thromboxanes, but I think it will also, serotonin is going to lead to vasoconstriction. The platelets will also release an additional compound called adenosine diphosphate. Adenosine diphosphate is going to help the platelets to recruit even more platelets, so that the platelet plug. So when they go and bind to the site of the damaged blood vessel, they are going to form what is known as a platelet plug. And so what will happen then is that as you recruit more and more platelets, the platelet plug is going to become big, and the idea is to seal the damaged part of your blood vessel. After you form the platelet plug, which is temporal, what will happen is through other complex, means of the number of clotting factors, which I think are maybe beyond the scope of this course, but I will still show you the list. What will happen is that you are going to end up activating an important protein in the blood, which we mentioned, which is fibrinogen, into fibrin, which will basically going to form a mesh around the platelet plug and make it hold firm and help you to reduce blood loss in that damaged blood vessel. Guys, I can see that you are tired with those few words. I would like to end this talk, but before I do, I'd just like to show you on slide 38 the various clotting factors that are responsible for helping us to maintain vascular integrity by a process of homeostasis. You may know that there are some people that do not have these clotting factors, and what will happen is that a little bruise, a little injection, they will bleed for hours. And this condition is called hemophilia. It's factor 10, right? They don't have factor 10 if I remember correctly. Okay, do you have any question? You're tired, eh? Okay, you'll be glad to know I have a recording. If you still want to listen to my boring voice, you are welcome. I shall post it to the classroom.